So my name is Professor David Gortler. I graduated from the University of Arizona with my PharmD in 1998. And as a pharmacist, I've had a little bit of an out-of-the-box kind of career. I did my general residency through the New York Columbia Presbyterian Healthcare System, after which I dove into research and did a vascular medicine basic science fellowship through the Yale School of Medicine. I worked for Pfizer as an investigational medicine research scientist, and after that I left to return back to Yale as a professor, finally settled down in Washington, D.C. and the FDA at Georgetown University. At the FDA, I was a senior medical analyst and medical officer in the Division of Metabolism and Endocrinology Products, and now I'm an associate professor of pharmacology at Georgetown. The FDA is kind of a little bit of a black box mystery to pharmacists and, well, anyone in healthcare. So I'm happy to dispel any rumors about how the agency does what it does and why it does, so feel free to ask. But the main part of this lecture here is to help dispel rumors about weight loss and obesity drugs, because there's a lot of misinformation out there. If someone were to just go into Yahoo and type in ways of losing weight, for instance, they'd be inundated with a lot of misinformation, as is the internet. So this lecture here that I'm going to be giving you guys today is going to be very much a summary of available data. Since it is a summary, there are going to be things which I'm not going to be answering fully. But if you have questions, make sure and email them per the email address, and I'll be happy to address them. I've spent over the last decade studying lipidology and lipids, and with studying lipids, one must go into obesity as well. And I could easily turn tonight's presentation into some 8-hour mega lecture. I could probably turn it into a semester-long course, really. But I promise I'll keep this presentation to be below the 1-hour mark, so everyone can enjoy their evenings. So with that, we'll go ahead and get started. Next slide, please. So I'll begin by talking about a little bit about the epidemiology. So here's what's been going on over the past 20+ years. It's no secret that the epidemics of obesity and diabetes continue to increase. If you look at the top left panel, you can see that back in 1990, no state had a prevalence of obesity that was higher than 14%. In contrast to that, in the year 2000, the prevalence was at least 20% in the majority of the states. 10 years later after that, it was 25% in many of the states, 2010. At the same time, diabetes has risen during the same 20-year period, with the prevalence of diabetes being higher than 6% in all of the 50 states. That most disturbingly, there's no evidence that what we see here is going to be the plateau. In fact, I'm not even sure what color the CDC is going to use after it uses red. We went from light blue to medium blue to dark blue to yellow. And just to show you how severe this is, I'm not sure how they're going to show that it's going to be more severe in the future. And like I said, there's no indication that we've reached our peak. With obesity, we see a whole slew of comorbid conditions, including heart disease, diabetes, hypertension, gallbladder disease, osteoarthritis, hirsutism, sleep apnea, other breathing problems, and certain kinds of cancers have been shown to increase and be directly related to obesity as well, including uterine cancer, breast cancer, collateral cancer, kidney, and gallbladder cancer. Next slide, please. So how did this come to be? Well, with the exponential development of equipment and devices, we made our lives quite comfortable for each other, and the level of energy expenditure has been substantially reduced. We spend a lot of time in our gadget-filled cars, and we are commuting in our cars longer than ever. We've also become addicted to our electrical devices when we're not inside the car. And I'm not just talking about things like smartphones and Xboxes. I mean things like elevators and escalators. I mean, who takes the stairs anymore, right? At the same time, we're increasingly exposed to energy-dense food of poor nutritional value. Thus, for these simple and obvious reasons, there's a current worldwide epidemic. And again, there's no evidence that what we're seeing right now is the plateau. Mother Nature has engineered humans to be quite efficient from an energy standpoint, and ancestors of humans had to survive very difficult environments in which energy from food was sometimes limited and the energy requirements were rather high. Today is the exact opposite. Next slide, please. The most commonly used index in the body is the body mass index, which is expressed as body weight in kilograms divided by height in meters squared. When populations are examined, higher BMI values are associated with a greater prevalence of comorbidities. However, in clinical practice, practitioners have been perplexed by the fact that equally obese individuals may or may not be characterized by the expected comorbidities of obesity. The reason for such differences was unclear. The hint as to why this is the picture on the top of the slide. BMI only takes sheer weight versus sheer height into consideration and makes no accommodation for whether such weight is lean or non-lean. In fact, if you look at the two pictures at the very top, the BMI could actually be the same in these two individuals, but these men would have very different metabolic profiles. The BMI makes no accommodation for that. Next slide. So we're going to examine two questions. BMI is the current standard, but are there better ways to assess metabolic risk? Is waist circumference better than body mass index a better way to predict cardiometabolic risk? Is total adiposity, or the total fat content in one's body, a better way to predict cardiometabolic risk? Waist circumference adds to the information provided by the body mass index. It helps practitioners identify the subgroup of overweight or obese patients likely to be characterized by a greater accumulation of abdominal fat. However, an increased waist circumference could be the result of an increased accumulation of something called subcutaneous fat or visceral fat. And I'm going to explain what these mean later on. Evidence suggests that one abdominal fat deposit is actually more important than the other when it comes to modulating the risk of diabetes and cardiovascular disease. Next question. For a long time, obesity was not considered to be among the so-called heavyweights of modifiable cardiovascular risk, cardiovascular disease. Risk factors that have traditionally included smoking, diabetes, and hypertension. Next slide. Although there has been a hectic investigation of potentially important modifiable cardiovascular disease risk factors, obesity, as defined by BMI, has failed to universally qualify as a well-recognized risk factor. This is partially because of the way obesity is identified, that is, using BMI, and explained by the aforementioned two pictures. Next slide. The lay press has addressed this issue with its traditional incompetence, unfortunately, with most things drug and pharmacology related, confusing the public with headlines such as these, and perhaps lulling the populace to the possibility that they may not need to lose weight. And just to point out, these headlines were all obtained within a 4-month period earlier in 2008. So let's go through them. First, starting on the upper left-hand corner, death risk climbs as waist circumference grows. So that makes it seem like perhaps if someone is overweight, and as their waist circumference grows, it's a negative thing. And then right underneath that, fit and fat. U.S. study shows it's possible. So that makes it seem like being overweight isn't so bad. Another, right underneath that, all U.S. adults could be overweight in 40 years. Well, that's not necessarily a bad thing according to the preceding title above that. Obesity can be seen as protective in the cases of heart failure. And then right underneath that, heart disease risk soars with obesity and diabetes. Now, if you look at those articles in the upper right-hand corner, you'll notice that one is dated August 5th and the other is dated August 15th of the same year. Just a mere 10 days, Reuters seems to contradict itself. And then finally, at the very bottom, the obese may actually fare better after stroke. So this is something which is very confusing. If a layperson were to read these articles, they'd get completely confused. And in fact, many health practitioners are confused by the whole thing as well. This is because the way their obesity is being assessed is using the BMI scale. It's outdated, and there have to be better ways of assessing obesity, and that's one of the things I'm going to talk about, in addition to talking about diet modalities and the pharmacology. Next slide. Although these articles were all collected back in 2008, this even carries on into 2013. And just nary even a month ago, in the Drudge Report, the most visited website on the entire internet, the recipe for a long life. Overweight people may actually have a lower death risk. Next slide. In this article, dated less than a month ago, the press seems to be confused as to whether or not obesity is a risk or not, with this article actually just plainly stating that overweight people actually have a lower death risk. Anyway, the next slides are going to be talk about exactly how obesity is defined and perhaps explain why there's such a confusion. And as part of the lecture to actually deduce whether someone is obese or not and whether it's dangerous or not, I'm going to show CAT scans, probably for the first time in a Pharmacy Times lecture. Obesity can be classified into two groups on the basis of body fat distribution and the waist-to-hip ratio circumference. This classification is easily understood by the public, easily relatable to just about everyone, and it also helps predict the risk of obesity-related health problems. There are two different ways people can carry excess fat on their body, giving them either an apple or pear-shaped figure. The apple shape is considered to be worse. It's also called android, abdominal, or also referred to as central obesity. People with the high waist-to-hip ratios are referred to as apples because their body fat is distributed mainly on their upper trunk and in their stomach, chest, and abdomen, giving them a sort of apple shape. These individuals, by and large, are male. The pear shape, also referred to as gynoid or peripheral obesity, are people who have a lower waist-to-hip ratio and are shaped sort of like pears. Their body fat is distributed mainly on the lower trunk, on their hips and thighs, giving them a pear shape. These individuals are, by and large, female. In contrast to the apple shape, the pear-shaped individuals have health risks which are minimal. Next slide. The heavier or more important a patient is, the more likely he or she is characterized by an increased accumulation of visceral or abdominal fat, giving them the so-called apple shape. There is a relationship between total body fat mass and visceral adipose tissue. For any given accumulation of total body fat, on average, men will have twice the amount of visceral fat as compared to premenopausal women, as shown by the upper blue line in the scatter chart. For one reason or another, the more weight that men gain, the more it will accumulate around the waistline. This is why more men will fit into the apple or android category of obesity, putting men specifically at a higher risk. Next slide. So visceral or abdominal fat is considered to be the more dangerous fat. So then the question begs is, why is having weights specifically around the waistline such a big deal? Well, this cross-sectional image of the abdomen obtained by CT scan, it usually is obtained by scanning the abdomen at the level of the L4 or L5, or more technically the belly button level. In this CT scan, visceral adipose tissue is digitally highlighted in bright white. Normally, a CT scan wouldn't show bright white fat coming up as bright white. And we see a lot of it here right at the L4, L5 level. Studies have indicated that among equally overweight or obese individuals, an excess of intra-abdominal or visceral adipose tissue is predictive of an increased risk of metabolic abnormalities. This image is important to understand why obesity is detrimental, particularly to those with visceral adiposity. You see, the fat that one has in their body, it's not just simply insulation. It's not just this extra stuff we carry around or this extra fodder. It's actually an active component of our endocrinology system. It's a major source of free radicals, free fatty acids, and cholesterol and inflammatory markers. All of these are bad things. Around the same belly button L4, L5 area, what else do we have? Well, we've got our vital organs, kidneys, liver, pancreas, all of which are being bathed in this fat and in turn being buried in free radicals and inflammatory markers that adipose tissue actively produces. One of the things which I learned early in my research fellowship, which was in a lab, is that everything is related to inflammation these days. All of it is a big issue. It's an issue when it comes to treating cancer, diabetes, heart failure. All of this stuff has inflammatory components. In fact, since my roots are really in cholesterol and lipids, I actually didn't know that when one looks at a cholesterol plaque, if you kind of have a cartoon image of what cholesterol accumulation looks like, you can see that there's imagine seeing a bright red coronary artery or carotid artery and then like a thick yellow plaque. I thought that thick yellow plaque, up until I started working in a laboratory, was actually all just cholesterol, but it's not. About half of that is inflammatory markers. What happens is cholesterol will stick to very specific parts of one's carotid or coronary arteries, And then what will happen is your own inflammatory markers will come and cover it up. And then another little piece of cholesterol will stick there, and your own body's inflammatory markers will cover it up. We're talking like foam cells, endothelial cells, smooth muscle cells, TNF-alpha, markers for high-sensitivity C-reactive protein, you name it. So it's actually a response that the body has, and it's an appropriate response. But today, if you were to actually do assay or do pathology work on a cholesterol plaque, about 50% of it is inflammatory markers, and it plays a big role in just about every disease state. Next slide. So now I'm going to add a little bit of a caveat to what I just said in the previous slide. In this slide here, we have 4 different scans of 4 different massively obese female patients. In contrast to the previous slide we saw, certain women tend to accumulate less fat viscerally and more fat subcutaneously. So even though the waistlines of females may be as large as males, their fat is not visceral. It's not bathing the organs. It's subcutaneous. These slides don't have any digital enhancements for fat, as in the previous slide, but the subcutaneous fat is shown in dark gray surrounding the perimeter of the scan, think outside of the rib cage in this area. All of these scans clearly indicate that certain obese women, even though massively obese relative to their kidney and spine measurements, have most of their fat accumulated subcutaneously as opposed to viscerally in the case of men. In particular,